245 pages memorized. Of course, right?
1,600, I think.
All right, we'll call this Medical Services Board meeting to order. And Judy, if we could start with the roll call, please.
Christy Blakely.
Present.
Patricia Gibbons is excused. Brigida Hughes.
Present.
Brenda Lacombe.
Here.
Paul Malinkovich.
Here.
Amanda Moore.
Here.
Jenny Riley.
Here.
Donna Roberts.
Here.
Mike Stahl.
Here.
Mary Young is excused. We have 8 here.
Great, thank you, Judy. General announcements, the date and location of the next Medical Services Board meeting. The next meeting is scheduled to be held March 13th, 2015, beginning at 9 a.m. at 303 East 17th Avenue, Denver, Colorado, here in the 7th floor conference room. It is a policy of this board and the department to remind everyone in attendance that this facility is private property. The capacity of the meeting room is 80, so please do not block the doors or stand around the edges of the room. And please turn off cell phones while in the meeting room, as they may interfere with the recording equipment. And with that, I'd like to have a motion for approval of the January 9th minutes.
Move approval of the January 9th minutes.
Second.
We got a motion, a second. Any discussion? All those in favor, say aye. Aye. Ms. Blakely?
I wasn't present, so I think I passed or something.
Okay.
And you can thank me later for not getting you out there.
Appreciate that. Thank you. Okay, so we have the meetings, or the minutes approved. We're going to change the agenda around just a little bit to get a legislative update first, so Zach can get back over to the Capitol. Welcome, Zach, if you'd like to kind of introduce yourself and give us your updates.
I like to make an entrance. Good morning.
Good morning.
So, I don't know. No? Okay. It is? It is. Okay. Good morning. My name is Zach Linkowitz. I'm the department's legislative liaison. I appreciate you taking the legislative update out of order. One of our department bills is up this morning for its first floor debate, so hopefully you don't have too many tough questions for me this morning, so I can get over there. I was planning on talking about 4 bills this morning, and I'm happy to take questions as well on others if you have questions on bills you've heard about. The first bill, you should have 2 handouts. One is around House Bill 1079. This is around our teen pregnancy and dropout prevention program, where I don't think we talked about this the last time I was here with the board, because we were still determining whether or not it would be a department agenda item. It's since been introduced and it's passed.
Excuse me, Zach. Ms. Blakely, could you put your phone on mute, please?
Sorry.
Okay.
So the bill, right now we have a teen pregnancy and dropout prevention program. It provides counseling to help teens make good choices and hopefully prevent unintended teen pregnancies, as well as keep them in school. It's been piloted over the last several years in Dalton, Mason, Montrose counties. Last year, they had 393 participants. They reported only 3 participants either fathering a child or having a pregnancy. So it's a very successful program. Right now, the program's 90% federally funded, 10% locally funded, and there's a statutory prohibition on using general fund for the program. So the bill removes that statutory prohibition so we can use general fund for the 10% match, and that way we can expand it to other communities that haven't been able to find local grant funds for the program. So we've gotten a lot of support from the counties. Colorado Counties Incorporated is actually taking up this morning for a support position. It passed finance, House Finance, as well as appropriations with broad bipartisan support, and it's up this morning for its first floor debate. I expect it will pass. That's sort of the update on that one. I don't know if there's any questions.
Just a comment, I really appreciate all your support on that. That has been a very important program over in Mesa and Montrose County, and so we appreciate your support.
Great. House Bill 1186, this is the department's Children with Autism waiver expansion. You also have a handout on this one. This was a department budget request that required some statutory changes. That's why it's a bill. The Joint Budget Committee had to vote 6-0 to approve a bill. So they've essentially approved the budget request and moved forward with the bill. It's going to have its first committee hearing on Tuesday. the ARC of Colorado, there's also several supporters for this bill. The ARC of Colorado is sort of coordinating testimony for Tuesday, but again, we think this one should pass and have broad bipartisan support. And I'll keep you updated as that moves through the process. There's another bill that you may have been hearing about from stakeholders.
May I comment a thank you for all your work and for the department's support on this? This will take 680 kids off a waiting list that all have autism and are in need of services. Thank you. Thank you.
Thank you.
I wish every legislative committee was like this. I'm generally not thanked when I go in front of committees. Another bill that you may have heard about, it's House Bill 1151. This sets a floor for Medicaid rates based on a percentage of Medicare. Gretchen's actually going to be talking about this later in her legislative update. So any tough questions about that bill, I'm going to defer to Gretchen. She's been very effective in front of our Joint Budget Committee, so we'll give her some more practice before next Tuesday's hearing. The final bill that I wanted to talk about today, or just give you an update on, is Senate Bill 11, and this is the spinal cord injury waiver renewal bill. It passed out of Senate Health, three with 2 excused, and all 3 were the Republicans, so the 2 Democrats were missing from the committee. So I expect it will move through the process with broad bipartisan support as well. Had some great testimony on that, and it will be up in appropriations next. It hasn't been calendared yet. With that, I'm happy to answer sort of any other questions on bills if you've heard about them or head out.
One question, I guess. What's the update on Representative Quorum's other bill, the LARC bill that he's looking at? Where's that at?
Yeah, so Representative Quorum is also sponsoring a CDPHE department bill, which would provide $5 million for their LARC program. The bill was introduced and has its first test or hearing February 17th. So I think our goal was to try and get our bill out of the House before that bill has its first testimony, because even when I was lobbying people, legislators, they were confused. I mean, it's a very confusing concepts between the two, and that we have the same sponsors is also as the confusion.
Right. Okay, that makes sense. Thank you. Other questions from the board? All right, great. Thank you very much. Appreciate it. We'll move into our rules portion now, and we have a couple rules up for final permanent adoption. If I could start with a motion for document 1, please.
I'll move the final permanent adoption of document 01, MSB 14-10-17A, revision to the medical assistance special financing division rule concerning the creation of the Colorado Dental Health Care Program for low-income seniors, 10 CCR 2505-10, section 8.960, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Got a motion and a second for document 1, and we have Nancy Dolson here to present. Welcome.
Good morning. Thank you, Mr. President, members of the board. Indeed, I am Nancy Dolson with the Special Financing Division at the department, and I am happy to be here today to ask for your permanent adoption of this rule, which creates the Colorado Dental Health Care Program for low-income seniors. Just a brief reminder about what this rule does. This establishes a $3 million state-funded program for dental care for seniors who do not have other dental coverage, either through Medicaid, our old age pension health and medical care program, or private insurance. Organizations that are eligible for funding are area agencies on aging, community-based organizations or foundations, public health agencies, federally qualified health centers, safety net clinics, private dental practices. And the intent is to have grants kind of begin on July 1st, 2015. The program guidelines and rules were developed under the guidance of a dental advisory committee, which was created by the legislation, and they worked very hard really in the fall to bring this before you. The rule establishes the definition of eligible seniors, how we determine that they're economically disadvantaged, maximum program payment by dental procedure code, and maximum co-payment that can be charged to seniors, and establishes our grant and award procedures. We do have just one change to the rule from what you saw last month when you adopted it on an emergency basis. On page 3 of 4 of the rule itself, on line 22, you'll see a small change. The qualified grantees have to submit an annual report to the department, and we had the reference incorrect. So it's been corrected to 8.960-.3.f. So that we have the correct reference there. When the rule was heard last month, we did have a stakeholder who made the request to this board that the rule be changed to allow an upfront payment of 1/12 of the expected award. And as you requested, I took this back to the Dental Advisory Committee and to our department's procurement unit. Our Dental Advisory Committee, there was quite a bit of discussion kind of electronically over email. Many of the members recognize that some small nonprofits may not have cash reserves on hand, but they also recognize, of course, that these are limited state funds. And the committee was concerned about not granting funds to organizations that might be financially risky, and that generally dentists have to bill and wait for payment. So ultimately, the majority of the advisory committee did not recommend this change. And then in addition, when we consulted with our department's procurement unit, they noted that the state can't make payments before goods or services are actually received. And to do so, we have to get a fiscal rule waiver from the state controller's office, which would be probably very difficult to achieve. Now, we do intend to make payments quickly and efficiently under this program to allow monthly invoicing to us. This won't be going through a claim system or through the Medicaid Dental ASO organization. Rather, we make, if you will, kind of direct payments from our Colorado's financial reporting system. And this is something that myself and my staff have a lot of experience with other programs that we manage, where we make direct grant payments out and are able to do that very quickly. And in fact, I even have an accountant on my staff to help with that. So with that, that change was not made in this rule.
Okay.
And so that's what I have for you this morning. I'm happy to take any of your questions.
Ms. Riley?
I need to inform the board that I oversee a department that includes the Area Agency on Aging.
Thank you. Comments from anybody on the board? No. We've got nobody signed up for public testimony. Would anyone like to sign up for public testimony on document 1? Okay, seeing none. All those in favor of final approval of document 1 signify by saying aye.
Aye.
Ms. Blakely?
Aye.
Thank you.
Aye.
Gotcha. All right, we've got approval of document 1. Thank you very much.
Thank you.
And I get logged out. Let's move on to document 2. If I could have a motion, please.
Move the final permanent adoption of document 2, MSB 14-11-04-A, revision to the Medical Assistance Special Financing Division rule concerning hospital provider fees, collection, and distribution, section 8.20000, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Have a second?
Second.
Very good. We got a motion and a second on document 2, and we have Matt Haynes here. Welcome, Matt.
Thank you, Mr. President, board members. Good morning. My name is Matt Haynes. I'm the Provider Fee Financing Unit Supervisor here at the department, and I will be presenting for final adoption Medical Services Board 1411-04A. We didn't have any changes to the rules from the initial, the emergency, but we did have some questions around the age good measures. Excuse me, specifically a request to provide those in writing. We did get those out to you guys. I hope that you had a chance to take a look at that. And a question around the ED process measure, which I will certainly address. In addition to that, I want to give the board an update that we have submitted the state plan amendment to CMS. We are now in that review process with CMS now. And with that review process, we've also had the model public since we were presenting with you folks. And we have had some questions around some data questions. With that review process with CMS and with data questions that we review with the hospitals, you know, knock on wood, we don't expect it or hope that there will be any changes to the rule, but just to, you know, just so we know that if there will be changes through that review process with CMS or do any of the review we're doing with some of these questions, that we may be back, knock on wood, hopefully we won't be back with any rule changes, but. And in regards to the HQIP ED measure, the question was around how that would impact Tala, and as we discussed last time, that is a process measure. As we look through the ED measure is not about limiting access to the ED or restricting care in the ED. What we're really focused on with that measure is, are the emergency departments and are the providers connecting the clients with information about primary care, the regional care collaborative organizations, and can we see that those processes are in place and that they can document those? And that's really the focus of that measure there. But if you do have any other questions regarding the HQIP, in relation to the questions we had, I'll be happy to take those now.
Questions? Dr. Malinkovich?
I had one question about the optional measures. Are the optional measures set so that in addition to receiving incentives for meeting base measures, you can also receive additional incentive for meeting the optional measures? Or are they optional in lieu of some of the base measures?
I will certainly, talk to the committee to make sure I have an accurate answer for you on that. But my understanding is that we've had in the past, when the program was there and we had the measures, there were some providers that would not qualify for measures, and that was a change to the program. So now that there's the base measures, and the ideal is that the base measures are first, and you should qualify for those. But in the event providers don't meet criteria to be able to qualify for those base measures, there's this list of optional measures so that all providers can still have the 5 measures, and we can have more equitable scoring across all providers.
So it sounds to me like the optional measure is in lieu of a base measure if you're not eligible to do
That's
a base
correct.
measure. Thanks.
Any other questions from the board?
I just want to thank you for the clarification on the ED, because that's the way that it's phrased in here is completely different than what I think Dr. Givens brought up at our last meeting in regards to just patient evaluation. This is much different focus of the patient education and how they're tied into their primary care provider. So I think you have adequately answered her concern that she had last month. So thank you for that
Great, I appreciate that.
clarification.
Is there anything that we could do to update what was written? Is that fine, or is there something we can do to make sure that's communicated more clearly?
Well, this little handout explained it perfectly, and I think that when I read that, I had a much better understanding of what you're saying. And I think also the emergency room process measure, the way that that's read, I feel like the last time in our rule meeting, it wasn't phrased as such. So I think that as long as this handout is available, that would clarify pretty well.
Okay.
So I don't think any further clarification is necessary.
Good, thank you. Any other questions from the board? Nobody has signed up for public testimony. Would anyone like to sign up for document 2, public testimony? Seeing none, all those in favor of final approval adoption of document 2, signify by saying aye. Aye. Ms. Blakely?
Aye.
All right, we've got approval of document 2. Thank you very much. Appreciate that. Moving on to the initial approval agenda, we've got 5 rules that we'll be hearing this morning. Could I have a motion for document 3, please?
Move the initial adoption of document 3, MSB 14-09-09-A, revision to the medical assistance community living rule concerning Colorado Choice transitions, parentheses CCT and parentheses. A money follows the person demonstration, section 8.555, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second?
Got a motion and a second for document 3. I'm logging back in again.
Yeah.
I'm logged out. Thank you. We have Nicole Storm here, along with, go ahead and introduce yourself, please.
Absolutely. Good morning, Mr. President, members of the board. My name is Nicole Storm. I am the project manager for Colorado Choice Transitions, otherwise referred to as CCT. CCT is Colorado's Money Follows the Person program here in Colorado. It is a 5-year, $22 million grant program with 2 primary goals. The first goal is to facilitate the transition of Medicaid-eligible clients from long-term care facilities to the community using enhanced services and supports, which we refer to as demonstration services. Those services are intended to help support clients as they become more independent in the community. Those enhanced services are available through CCT for 365 days, which is equal to the client's participation in the program. After that 365 days, the client is disenrolled from CCT, but so long as they remain Medicaid eligible, they stay enrolled in the HCBS programs. The second goal is to establish a rebalancing fund. For every dollar that we spend on services, 25 cents of that is set aside for a rebalancing fund. And the purpose behind the rebalancing fund is to establish long-term services and supports reform efforts. So we're here today to talk about a couple of different revisions that we're doing to the current rule. As a demonstration program, we are constantly looking at our processes and procedures and looking at ways that we can improve them and make them more efficient. When we first wrote this rule back in 2012, we had not yet operationalized the program. That is, we had not started transitions. In the last 2 years, we've learned a great deal of what works and what doesn't work. So what we've done is we've gone through the rule and just sort of cleaned it up and made it reflect what we're actually doing in practice with the program. The second thing is that we're removing 2 of the demonstration services. That is the transitional substance abuse benefit and the transitional specialized day rehabilitation services. And that is due to underutilization, low provider enrollment, and the fact that those services can be accessed through either the state plan benefit, substance abuse is now available through the state plan, or we feel that clients will not experience any hardship if we do away with the specialized day rehabilitation services, because they'll be able to receive those adult day type services through the HCBS waivers.
Question on that, I guess, are there some individuals currently utilizing those services right now that will be notified then by the state of how they can continue those services?
Of the 2 services, we've only had 1 client access the substance abuse benefit, and we have not had any clients access the transitional specialized day rehabilitation services. The 1 client has only utilized $150 worth of that service, and we're confident that they'll be able to receive similar services through the state plan.
Okay, thank you. Anything else on the rule that you want to bring to our attention?
I think that basically sums up what we're trying to accomplish here today.
Okay. Questions from the board? We do have somebody signed up for public testimony. Thank you. We have 3 people signed up for public testimony. So the first person I'd like to call up is Lynn Crooks. Please come up, introduce yourself, who you represent, and your position on this rule.
My name is, my name is Lynn Parker Crooks. I am a parent and guardian of an autistic son who is 45 years old. I did type up a letter. Unfortunately, my printer ran out of ink.
That always happens.
Yes. So I have 8 copies of it here, and what I would like to do is just read it.
Okay.
And then you can pass these out. And I only have 1 copy of this. This is my son's signature, so I just wanted you all to be able to see that he can sign his name. Okay. My son, David Gregory, is 45 years old, severely autistic, and has tested to the mental ability and language to 5 years old. As many of you know, this testing does not mean that he understands as much as a 5-year-old. He is extremely physically strong. In fact, he's known as the strongest man who's ever been in Wheat Ridge Regional Center. And when he becomes upset, one of his actions is to destroy property. And when he's confused or agitated, that's what he sometimes does. And just to give you an idea, that means he can rip a toilet off of the floor. He's also pulled a door off of a van because the door was broken, and so he fixed it in his mind by taking it off. David is afraid of dogs, and he would run into busy traffic. I mean, he'd run right in front of a semi to get away from a loose dog, because he does not have that safety understanding. And he also will take food out of trash and eat it. And he's living right now in a group home in 59th House in Golden, Colorado, and that's under the Wheat Ridge Regional Center. And this setting provides excellent oversight for him. It's got 24-hour care, it's got doctors and psychiatrists for the kind of medication. I think he's on 8 different medications, something like that. Now I have some concerns about, there was a proposed wording, and I think you've changed it back. Let's see what I did. Here it is. In the CCT enrollment part, the first one is 85556A, and it says, client shall demonstrate by signature that he or she provides consent to participate in the CCT demonstration program, understands the roles and responsibilities of the client, case manager, and transition coordinator, and agrees to participate in the program evaluation. Well, you can see, if you pass that around, David can sign his name. But that is actually a visitor sheet from his house, and I said, oh, we have to sign you out. And so he grabbed the pencil or pen, I can't remember which. I have it on my refrigerator because I think it's great. He's remembered after all this time to still write his name. But he wrote his name. So that's what he understands. He didn't understand why he was signing the paper, but he was going to cooperate and sign the paper. Okay. And the next one is guardian shall demonstrate by signature that he or she provides consent for the client to participate in the CCT demonstration program, understands the roles and responsibilities of the client, case manager and transition coordinator, and agrees to participate in the program evaluation activities. So I guess what my concern is that if you have in here clients agree, and then I would say a guardian such as myself disagrees, then you're going to have a conflict there. And I just want to make sure, because a guardian is obviously appointed for all of the reasons that you know about, I just want to make sure that this kind of conflict would not come up, because you could get David to sign anything, and he wouldn't understand what any of it was. And so I just want to make sure that there isn't a problem with that. And I do appreciate the not changing the part about the guardians. I know you had some different wording in there at one time,
Okay.
and it's not there on this sheet anyway. So thank you very much for your time.
Ms. Storm, what's the department's feedback on that concern?
Well, clients that participate in CCT are also enrolled in one of 5 waivers. Persons who are elderly, blind, and disabled, persons who are brain injured, our community mental health supports waiver, supported living services waiver, and persons who are developmentally disabled. For those folks that are able to sign, it's important for them to acknowledge their consent and agree to participate in the program. For those folks that may have more cognitive difficulties in making those decisions for themselves, that is why we included the language for the guardian to give their consent on behalf of the client.
And I'm not sure, I mean, should there be an or in there? An and or between the client and the guardian? Did you look at that, or does this seem to meet both needs?
That is something that we can certainly look at if that would make the board more comfortable.
Yeah. I think for the second reading, as this comes back, let's look at that and make sure that we're not putting ourselves in a conflict between the two. Great.
Thank you. I appreciate it.
Thank you very much for your testimony. Besides that, you're in favor of this rule?
Yes.
All right, thank you. Next person signed up for public testimony is Veronica Roberts. please come forward and introduce yourself, who you represent, and your position on this rule.
Thank you for allowing us to come and talk to you all. My name is Veronica Roberts. I am the guardian for my son George Augenbaugh, who resides also under the Wheat Ridge Regional Center Depew House group home. He's been there a long, long time. I just did an outline, and basically, I agree exactly with what Lynn just told everyone, that our loved ones, most of them can sign their name, a great number of them can sign their name, but they don't have the understanding of what they're signing. George is 49, but he's 7. So, at the most, he's 7. So he's got severe mental retardation, including physical aggression and self-injurious behavior pattern over the years, encephalopathy, schizophrenic or schizoaffective disorder, excuse me, history of profound self-injurious behavior and aggression. He's actually had some grand mal seizures over the years. He's got cerebral degeneration. Some of this is as a result of all of the injuries he's done to himself over the years. So, to the point of this hearing, he did learn to print his name. I didn't bring a copy of George's writing, but he can print his name, George Augenbaugh, which with all the GHs, you know, it's a pretty good accomplishment. However, he'll proudly print his name for you anywhere you aim him to sign, but he won't understand what he's signing. So that was our concern. We don't want to remove the guardian's role in determining what would be best for our person. So that's basically the gist of it. It's
Great.
kind of a repeat. I'm so sorry.
Okay. That's quite all right.
Been said.
All right. Thank you very much for your testimony, though, and I appreciate you coming forward. Thank you. The third person to sign up is Josh Winkler. Like to come forward, Josh? Introduce yourself, who you're representing, and your position.
I'm slide vocals. You guys hear me on that?
Pull it forward just a little bit.
Where we go? There you go. So Josh Winkler, on this one, I'm testifying on behalf of ADAPT. And you guys probably all hear ADAPT from time to time, but I don't know how many people actually know that it stands for American Disabled for Attendant Programs Today. And so ADAPT has been behind MFP on the national level for well over a decade, been working on helping get ways to keep people out of institutions into the community. And Colorado was not one of the leaders in getting, the first MFP program out there. We're one of the later states to actually get around to getting MFP rolling. And the hope would be that it worked flawlessly when it came out by the time we learned from everybody else's mistakes. But like any program, that's not true. There's still problems at the federal level. There are still issues at the state level. And today I'm just voicing support for continuing to make changes to the rules. The program is not as good as it could be, and there are probably going to be more changes that need to come. There's still efforts at the federal level to improve things. There's still efforts, just within policy and procedures and guidance to providers. And the department's been working quite well with ADAPT and other organizations to try improving this program. But there still are a lot of issues, and the goal's never been to force anybody out that doesn't want to leave. It's very voluntary, very much made. Before you can get out there has to be a lot of proof that everything's in place, everything's ready, there really are the services you need, there really is the housing you need. There's a lot of things to line up in order to get somebody transitioned out of an institution. And for a lot of people, there still aren't those services available in the community, or maybe not in their particular community in the state. So it's not going to be for everybody. We still have a long ways to go on the community-based services side. But this program is helping get people out of institutions and hopefully get them the lives they want in the community. So just want to say thanks for continuing to bring improvements to the rules.
Great. So the way this is being presented, you're in support of
Yeah,
this rule?
it's a small step, but there's a lot more to be done.
keep the ball rolling.
I'm sure Tim and Nicole will be back many times.
I'm sure you'll continue to keep them honest with coming back.
So for those of you who do know ADAPT, we did come to visit Gresham on our first day to have a little meeting about this program.
Nice welcome party.
Great. Thank you very much. Any questions for Mr. Winkler? Great. Thank you very much. Is there anyone else who would like to sign up for public testimony on document 3? All right. Seeing none. Any other questions or comments from the board on this rule? It looks like probably just clarifying that guardian versus client area and then bringing it back. So we appreciate all your work on this. So all those in favor of initial adoption of document 3, signify by saying aye. Aye. Ms. Blakely?
Aye.
Very good. We got initial approval. Thank you very much.
Thank you for your time.
Moving on to document 4, if I could have a motion.
I move the initial approval of document 4, MSB 14-04-15-A, revision to the medical assistance ruling concerning long-term care services, 8.400-8.499, incorporating the statement of basis and the purpose of the statutory authority contained in the records.
Second.
Got a motion and a second. And we have Jason Tataki and Micah Jones here. Are you going to go over all 240 pages of this rule for us, line by line? Thank you very much. Yeah, lunch is on its way. Thank you very much for the crosswalk on this. If you could kind of just give us an overview of what we're doing with this rule and then some of the real substantive changes that are put in place, that would be great.
Certainly, and thank you, and good morning, Mr. President and members of the board. Once again, my name is Micah Jones. I'm the PACE Contract Manager. PACE stands for Program of All-Inclusive Care for the Elderly. Next to me is Jason Takaki, Unit Supervisor for Supportive Living Options. We're here today to talk about LTSS's revisions to the long-term care regulations, starting at Section 8.400 through Section 8.499. Now, for a little bit of background on why we undertook these revisions, in 2012, Governor Hickenlooper signed an executive order which required state agencies to conduct a comprehensive review of their regulations to ensure that they're innovative and less burdensome. Now, for LTSS's review of the long-term care regulations, we started this in 2013. Now, we did not look at any policy. So to go to your earlier point, Mr. President, there were no substantive changes to the long-term care regulations. Instead, we looked at our rules to clean them up to make them more efficient, elegant, and user-friendly for all of our stakeholders. To accomplish these goals, we removed and replaced outdated offensive language, and to that end, we made our language more person-first or person-centered language to our rules. We corrected spelling errors. We corrected grammatical errors that do not affect the meaning or intent of the regulations. We standardized the citation format. Throughout the rules, there were various different uses of citations that were unclear. We simplified that and made everything easier so that when people would need to go to the federal regulations, it would be much easier to do so. We corrected inaccurate citations or citations that are no longer accurate. And we updated language to reflect current practice. Now, I would like to reiterate once again, there were no substantive changes to these regulations. Now, as far as our stakeholder engagement is concerned, we undertook a very robust stakeholder engagement process. The first thing we did was on our HCPUF website, we created a web page specifically for our regulatory efficiency review. To generate traffic to that web page, we sent out a mass email to all known stakeholders. And included in that email was the link to the web page, as well as information on who to contact with questions. In addition to that, at any event where there would be stakeholders, LTSS managers would announce and reminded the stakeholders that we are undertaking this review and that their comments are encouraged. And also at the Nursing Facility Advisory Council meetings, which were held once a month, the regulatory review was a standing agenda item, and we solicited comments at that point as well. Because of our outreach, we received comments from two different entities. The Colorado Cross Disability Coalition, as well as Myers and Stopper LC. And as you can see, our rule is over 200 pages long, but we have also included the crosswalk for the board. And I would like to take...
Very much appreciated.
And I would actually like to take some time to point out some specific items to the crosswalk that I definitely think needs the board's attention. Now, if you pull up your crosswalk on the very first page, the third row for section 8.40012, under language post change, it says C rule.
Right.
All right, I wanted to elaborate on that. I wanted to make sure that the board was able to see what we did there. So section 8.400.12 deals with the waivers and the home and community-based services. And what we did there was, as the rules are currently written, some of the waiver programs are no longer in existence as they are currently written. For example, the persons living with AIDS waiver has been rolled into the persons who are elderly, blind, and disabled waivers. So we updated the language to reflect that. We also spelled out the specific waivers in these regulations as well. Now, if you turn to, it should be page 5 of the crosswalk. Towards the bottom, the second from the bottom, section 8.40014, client who has a mental illness. This is something that we...
Hold on, what's the number that we should be looking at? I think our numbers may be off.
Yeah.
Oh, I apologize. It is section 8.40014.
It's about a third of the way, or
Okay.
2/3 of the way down on page
6. Yep, okay.
Now, that is something, due to time constraints, that is something that I did not have the opportunity to verify yet, so this is something that I do need to clarify, and I wanted to point that out to your attention.
Okay.
Now, are there any questions so far about what I've already said?
Dr. Milankovich?
Could you, it says, what I'm reading here, it says check with waivers to see if this is, I can't read anything else. What is it?
Accurate.
Accurate.
Okay.
This was done in Excel, and some of them were...
No, I understand why I done it up that way. I just couldn't.
Okay, and so how the detail is broken down was we ordered it by reason for the change. And then from there, we ordered it by rule sections. So on the first, as you see from the first page, the first 2 changes were just address changes. And then after that, it goes into changes that we made for clarity. And as you continue working through the crosswalk, you'll see that the lion's share of our changes were actually correcting citations and removing and updating outdated and offensive language. And we also have several changes that were in place for updating to current practice, and we have numerous changes for spelling. So as you can see, there was nothing substantive that we undertook with these changes. So I'd be more than happy to answer any questions the board may have.
Did we use spell check this time on spelling all those things?
Spell check is very important. Sadly, it doesn't catch everything.
Ms. Roberts?
I have a question, and this may be totally out of your ability to change, but in the present Mass Pro PASSAR form, On line 1, it asks if a person has a terminal, or if the person is terminally ill, yes or no, which you would think that that would immediately supersede anything else. But then on section 7, 22, it asks if a person is terminally ill, and you check yes. If you check yes, it's also under the caveat that the person also has had a major medical illness, is mentally retarded and/or developmentally disabled, which there shouldn't be that extra caveat there if the person is solely terminally ill and hasn't had any of those other diagnoses. So I don't know if that's an ability to discuss with MassPro or not.
Well, MassPro is no longer in business.
Okay.
They went bankrupt, I think, last year at some point. But the PassHeart program is administered by a different team, but we'll definitely bring it up. And that, again, that indicates an element on this regulatory review. When we started doing the whole rule section, I wanted to highlight the fact that we also incorporated a cross section of the entire department. So our LTSS rules kind of impact everything from budget to provider enrollment to waivers. And so part of the initial process was to just farm out identified sections across the department for their input. And that was a concern or a consideration going forward, that we need to align our rules with all the documentation that we have at the department to reflect the rules. So it's a good case in point, and I will bring this up with the community options team.
Okay. The section under medications, and if it's a nursing home that is filling this out, and a person is terminally ill, it does sort of have a little caveat there that if a person is, if it's medically related, which seems kind of counterintuitive because many of the behavioral drugs may be medically related, but in terms, it says if it's given for a medical purpose, then it doesn't have to be listed, although it could be for behaviors because of the inability of a person to have good cognition and inability to control outbursts, etc. However, in hospice, we often use Haldol, which is an antipsychotic for nausea, or we might use a sleeper like diphenhydramine, or we might use an anxiolytic for either opening bronchial airways or for mitigating some of the pain due to terminal agitation. And again, those are just solely purposeful for that person's terminal illness as opposed to any other behavioral issues. So just those two thoughts, please.
Great.
Thank you.
Well, another point that you just brought up as well is the interagency cooperation and collaboration on these rule sets. And I've been sitting on the work group for Colorado Department of Public Health and Environment. They're undergoing this regulatory review process as well. But again, there's this tension between what they put down on their, definitely with regard to the nursing facility survey side, the detail that they have in there, and then you look at our rules, we're a little bit off. And so hopefully, if you can really have that interagency collaboration on the rule sets, then perhaps we can really address that and nail it down in the future.
I think this would help SNF employees, because people that are doing MS or the minimum data set and such like are not necessarily, they may look up the diagnosis or the type of drug and just immediately put down that it's an anxiolytic or a psychotropic or some such thing, and not realize the different use of that medication in varying situations. So I appreciate that. Thank you.
Thank you.
All right, thank you. Other questions from the board on this rule? For a 245-page rule, you boiled it down very nicely, so I appreciate that. And again, thank you very much for the crosswalk to kind of show where the changes are. Appreciate that. Nobody has signed up for public testimony on document 4. Would anybody like to? And seeing none, all those in favor of initial adoption, please signify by saying aye. Aye. Ms. Blakely?
Aye.
Any opposed? Seeing none, we have initial approval. Thank you both very much for all your work.
Thank you very much.
Moving on to document 5, if I could have a motion?
I move the initial approval of document 05, MSP 14-11-19A, revision to the Medical Assistance Health Programs Provider Relations and Dental Program rule concerning adult dental services Section 8.201, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second?
Got a motion and a second. And we have Bill Heller and Sarah Tilleman here. Welcome. You guys have done a lot of work on this. We have a complete redlined version on our iPads as well as a clean version, and I'd leave it to the board, I think, a little bit of which version you'd like to work off of as we move forward. Does anyone have a strong opinion of either way?
Mr. President, if you, we actually got kind of a little walkthrough that we think that might help you as well.
Perfect.
And Sarah can let you know which page we're on, I believe the clean version.
No, the red line.
Okay, red line.
I didn't get the line version of the clean version in time to cite it that way.
Okay.
So we can help you out.
Okay, so we'll go to the red line version. Great, thank you.
Thank you, Mr. President and members of the board. My name is Bill Heller. I'm the Director of the Dental Programs and Provider Relations Division for HCPF. And I'm here with Sarah Tillman to present for you the revision of the medical assistance rule concerning treatment of oral medical conditions for adult clients, Section 8.201, MSB 14-11-19-A. And I'll just give you kind of a quick synopsis of where we were and where we are now. And then Sarah, who is our walking CDT 2015 book, will walk through all the technical pieces for you, and we'll answer any questions you might have. So, as you might recall, back in January and February a year ago, we came and presented a pretty skeleton version of the adult dental rule so that we could get the basic preventative and basic minor restorative benefits into place for our April 1st, 2014 date. And then we had presented to you a revision based on the benefits collaborative process, a rule for the children's benefit, and we just got that passed back in October and November of this past year. And so what we've done now is made a more robust rule with the adult dental rule. We've basically tried to sync it up with the children's rule, make sure the language syncs up. For instance, we had in the old children's rule and the adult dental benefit rule, for instance, on emergency benefits, we had a 12-hour definition in there that tried to define emergency, and that was very difficult for the practices to try and understand what fell under that category. So we redefined that, synced it up with the children's rule, which has been working quite well. We haven't had any problems there. And then we cleaned up language, for the most part, broadened the access to the benefits and made it easier on the dental offices, quite frankly. We had the ability through our administrator, DentaQuest, to do what we call post-payment review of claims. So instead of doing a pre-admission or a prior authorization, which you see generally, a lot of these services we're able to have the physician do the service and then provide the same kind of documentation you would have to prior to the service so that the client didn't have to wait. And so that's what we called our PPR process, and it's been well received. Now, I would point out, we didn't open that up for every procedure. We still have some procedures that we wanted a PAR on. So with that, I'll turn it over to Sarah, who will kind of walk you through the details of what changed and where. And if you have any questions, we're happy to answer. Thank you.
Thank you.
Good morning, Mr. President, members of the board. My name is Sarah Tilleman, and I am the Medicaid Dental Program Policy and Operations Specialist.
Nice.
All right. So looking at the red line version, which I know is a little cumbersome, I would like to briefly walk you through really what these changes boil down to. In the definition section, which on my version is page 1 of 16, 2 of 16.
6 of 21 on your iPads.
Thank you, Mr. President. I knew I could rely on you to help me translate those today. Really, all of the definitions that you see added to this section were definitions that were included in the children's rule. So all that were pertinent to adults, some were children really only, all that were pertinent to adults were just brought forward. So that's just to sync it up and make sure we've got the same definitions in the same places for the same procedures. Moving on to the oral evaluation section that starts on page 2. Again, a lot of this is just aligning the legal and reimbursement language, but it's also in this section really where we try to add the per provider or per location flexibility. In the original version of the rule, there is no flexibility on the oral evaluations. It's 2 per year. We wanted and we heard from our provider community that wasn't quite feasible. But we have to keep in mind that this is a limited benefit as approved by the legislature, so we got creative and with our with counseling from our dental directors at the ASO, the Administrative Service Organization, DentaQuest, we came up with what we think is a pretty good compromise. So keeping in mind that our population's a little bit more mobile and we may need to have that new client visit a little more frequently, we think we've built in those parameters. So that is what a lot of that redlining is. And it's more confusing in the rule than it is in the billing manual. So if that helps. Moving on.
Can I, hold on.
Oh, yes, please.
Can I stop you there?
Yes.
Can you explain it a little further? What are we actually What are you actually allowing here? More than 2 a year?
What I'm allowing, so in this section, there are 6 oral evaluation procedures. Periodic oral evaluation for an established patient, comprehensive oral evaluation for a new or established patient, or comprehensive periodontal oral evaluation, new or established patient. Of those 3, those are really for the new or established patient. 2 of those are going to remain 2 per year. Let me back up. These are all 6 of these are part of, fall under that 2 per year umbrella. I'm going to split them into 2 groups and edit the 2 groups off of each other. So already there I've added in another layer of 2 per year, but now within 2 different breakdowns. And I can give you a very detailed write-up on this, I promise. With that being said, we didn't want to just make it per provider or location across the board. Then the frequency limitations almost mean nothing. So we looked at the new patient code, the one that's really used when a new client walks into a dental provider's office, and that is the comprehensive oral evaluation. So that one we added per provider or location. So those are the general. We're walking into the office and we're looking for oral evaluation, not we're presenting with a problem. That's group B.
I guess what I'm trying to understand is, are you basically saying 2 per provider or location, but in fact, if there are more than one location, you'll pay for more than 2?
Yes, for certain codes.
For this code, for the new comprehensive evaluation.
Go to another office.
They move from Grand Junction to Denver.
Yes.
Then you're going to pay again.
Yes, so yes,
Okay.
sorry.
Right. We don't want to limit that, so they go from Denver to Grand Junction. The doctor in Grand Junction has never performed that evaluation.
Starts all over.
Yes.
So but now on somebody who presents with a problem, that's where we live.
Yeah, got it.
Thank you. It's the most complicated part of what we did with this rule, so.
Yeah, I was just trying to figure that out. Thanks.
Yes,
Thanks.
exactly, so were we. So thank you for those questions, and please let me know if there's any others. Any other questions on oral evaluations before I move on to diagnostic imaging? All right.
Thank you.
Diagnostic imaging on pages 4 through 5. Again, a lot of the redlining is just cleaning up the reimbursement and legal language and aligning the definitions with the legal definitions of the services. And then I would like to point out that on section 8.201.2, point A, point 2, point B, which is much easier to read if you just look at the top of page 5 of 16.
On which line?
Line
3?
3 through 8,
Okay.
intraoral periapical first image.
Yep.
There was a nonsensical typo in the first rule on that limitation. That has been corrected. It is 6 per year. It used to be 1 per 5 years, which really was a typo. So I just wanted to point out that has been corrected. The other thing to point out in diagnostic imaging is, again, we heard the call from our provider community that per provider or location would be appreciated on diagnostic imaging. And this one was a little bit more of a struggle for us. We hear them loud and clear, but we have to keep in mind it's $1,000 annual maximum, and you can eat up that very quickly with diagnostic imaging. So we are working very hard to promote a little bit of record transfer procedures through offices, and we would always like to see those get more sophisticated in the future, but that was part of the compromise. But understanding that doesn't work all the time, and there are definitely different providers in different situations, we did agree that per provider or location would be appropriate on vertical bite wings and panoramic imaging, and that's page 5, lines 23 through 28. So you will see that added there.
Ma'am, what about at nursing homes?
Excuse me. We'll take public testimony here in a little bit. If you'd like to sign up, there'll be a sign-up sheet back there, and you can ask all your questions at that point in time. Thank you. Go ahead.
Any other questions on the diagnostic imaging section? Moving on to minor restorations, I just wanted to point out on pages 6 through 7 that the main things here is that we accidentally omitted in the first rule coverage for prefabricated stainless steel crowns. So you'll see that added here, lines 17 through 20. And directly below that, lines 21 through 22, you'll see we added protective restorations. Also an omission in the first rule, and also a little bit of looking ahead to some future virtual dental home model policy. So that is why it's been included. I'm just going to keep moving on. Please interrupt me if you need to. Major restoration section on page 7 through 8. This is really about crowns. A lot of redlining. It was just aligning with the children's rule around legal and reimbursement language. We did remove the prior authorization from this section, but it wasn't in this section. It was on the prior auth list, but I just want to point that out, that we removed that, so we'll cover that later. Moving on to the endodontic services section, pages 8 through 10 of 16. This was all also legal and reimbursement language cleanup. We did retain the prior authorization requirement on retreatment of root canals. We removed it from root canals. Any questions? Okay. Moving on to periodontics, pages 10 through 11, we just, in alignment with the children's rule, made sure to add the gingivectomy services, and that's lines 4 through 12 of page 10. And again, we heard the cry from our provider community, and were advised it would be clinical best practice to include coverage of full mouth debridement for adults. So that's on page 10, lines 10 through 25. It is one of those procedures that we would like to, as Bill mentioned, go to prepayment review, not require the prior authorization. We also heard loud and clear from our community that that would be very cumbersome. So we didn't want to do that, add that barrier. In removable prosthetics, the denture section, pages 11 through 12.
Excuse me.
Yes.
Ms. Roberts.
Thank you, Mr. President. I just question on your gingivectomy and gingivoplasty.
Yes.
Gingivoplasty, gotta get the right emphasis on the syllable. Is there a caveat that if a person is being medically treated for, let's say, oral cancer, would that be under a different coverage than a dental benefit if it is related to the oral cavity?
If the service is being provided by a dentist, no, it falls under this. But if it's being provided by a medical practitioner, then no. So and that's one of those few practice areas where it could go either way.
Okay, thank you.
Okay. Thank you.
Thank you. Moving on to oral surgery, palliative treatment, and anesthesia, pages 12 through 13. Again, we heard it was quite cumbersome to have the prior authorization requirement on the deep sedation and general anesthesia services themselves. It's more appropriate to have that on the hospital-based services case, and that is how it's set up in the children's rule. So you'll see here we removed the prior auth requirement from these services. And everything else really under the oral surgery section is cleaning up legal and reimbursement language. And then that rolls right into the hospital-based services section on page 13 through 14. This entire section was accidentally admitted in the original rule. So we've brought it forward exactly as it appears in the children's rule, especially in light of removing the prior authorization requirement from the general anesthesia services and asking them to just submit the hospital case for a review. So that leaves a lot more flexibility for the providers and should reduce burden on those hospital-based cases quite a bit. And I think we all know that there are plenty of times where a client in an office needs sedation, and that's a lot different than it being admitted to the hospital. So that's what we were trying to get right on. Finally, just I think to summarize, on page 15 in the prior authorization required section, this is really where you see we removed a lot of the prior authorization requirements, and we will have those services go to a post-treatment prepayment review instead. This would be single crowns on page 15, line 17, root canal treatments on page 15, lines 21 through 22, non-emergency surgical extractions, which is page 15, line 23, minor surgical procedures, line 24, and as I just mentioned, the general anesthesia, deep sedation, lines 27 through 28. And then we made sure to add the requirement for hospital-based services on line 26.
Mr. President?
Yes.
Thank you. I also just wanted to point out, because there were a lot of changes in this, and Sarah kind of talked about the fact that this was missed originally. This was bringing up a brand-new program, so we were kind of learning on the fly, and as we got into this, what folks needed or didn't need, and how to make it work better. So kind of I just wanted to kind of plant that overall theme, so you didn't get the sense that we were asleep at the wheel first time around.
I was wondering who approved the rule the first time around.
Nor were you.
I really appreciate you, the consistency between the children's and the adult rules and stuff. That consistency is an important piece. It sounds like you've done a lot of work with stakeholders. Are there specific areas that you weren't able to come together in agreement on?
I would say it's probably that we didn't add per provider or location to as many of the services as they would have liked. And again, as Bill just alluded to, this is a brand new program, and we are trying to be very diligent about walking that line between access and being fiscally responsible in light of a $1,000 annual max. We have every intention, when we have a year's worth of utilization data under our belt, of looking at where we can make further improvements. But we were about 7.5 months in. Yeah, so we don't quite have that data yet.
Okay, great.
Right.
Dr. Milinkovich?
Thank you. Can you explain to me how post-treatment, what did you call it?
Post-treatment
prepayment review works?
Absolutely. Everything that you would do to submit for a prior authorization request, preoperative x-rays, a documentation of medical necessity, what this allows instead is for that documentation, instead of being submitted and getting prior authorization before the service is even rendered, it says take that documentation and send it in with the claim. We trust you, Dr. X, to know that root canal was needed. And your best clinical guidance, allows you to treat them then and there in the chair and submit that documentation as part of the claims reimbursement process.
And just to follow up, if I as a dentist then submit all that information, I will get paid?
I don't guarantee payment, but I outline clinical criteria to the nth degree in the office reference manual, which is their billing manual. And there's always, just like with our other utilization management vendor, there is a reconsideration process and there's a peer-to-peer review process. So a clinician can talk to another clinician if they don't like the original determinations.
So it's possible that I could do the treatment, submit the documentation that I think is sufficient to be able to be paid and not get paid?
It's possible, and this is something we discussed in detail through the Benefits Collaborative meetings that were held August of 2013 through February of 2014, and the providers still agreed that that was something that they really wanted to go with, and that as they got more and more used to how the benefit was being managed, they would get a really good sense for...
The worst of two evils. It's easier, yeah, no, I'm just... Got it.
Well, we don't preclude, so let's say you were a little nervous about a procedure, you could submit that information prior to and get a sense. So, we don't shut the door on the process in the front end.
No, I think it's, I'm actually, it sounds like a good process. I'm just
It was new to us as well.
being a little
and very-
facetious.
It was new to us and very exciting that our new vendor could offer us that.
And just as a point of clarification, so Sarah mentioned the Office Reference Manual. That's the billing manual, and it essentially outlines, here's the code, here's the documentation we'd need if it was a PAR, and we'd say that same kind of documentation if it was the PPR. So it outlines what you need to submit, these x-rays or this documentation to get this code.
No, it actually sounds like a much better, I mean, it's much easier than the prior authorization process.
I think most providers are happy with
Yeah,
with
I'm
it
sure.
being a new option.
Do we have other questions from the board at this point? Yes.
Can
Ms.
I
Lacombe?
just ask a question on the annual limits on number 2? We know that partials and dentures are pretty expensive. So how did you come up with that Medicaid allowable rate?
So, Mr. President, members of the board, we actually, I want to strongly point out the partials and full dentures are not subject to the $1,000 max. But what we did is, based on research, we went to other states, state Medicaid programs, essentially established what we thought was a reasonable rate for those two procedures, which was certainly, when you put the two together, well, not well above, but certainly above the $1,000 max. Now, it's not a commercial amount, but we heard, you wouldn't believe the gamut of price ranges that we heard on dentures. That I think I heard one as low as $300 for, and upwards of $5,000 to $6,000. So,
Thank you.
You
Yeah,
bet.
and I just asked because, working with some of the providers in the Pueblo area, it was interesting, the range of
right,
pricing.
absolutely.
Right.
And we were incredibly happy, both for, we got great support from the community to help get that denture and full mouth and partial in and not subject to the $1,000 max. So that was a great collaborative effort.
That was great. Yeah.
Ms. Roberts?
Thank you, Mr. President. I just want to thank you for your exhaustive work on this, because it's basically created a new entity, and you've done a phenomenal job.
Thank you, and you captured the process well there. It was a new insurance company, essentially.
We have 3 people signed up for public testimony at this time. So could we first have Marilyn Ketchum come forward, introduce yourself, who you represent, and your position on this rule?
Good morning.
Welcome.
My name is Marilyn Ketchum. I'm the dental director for Intercity Health Center, and I'm here on behalf of the Colorado Dental Association. I treat this population, our practices at 38th and York. And I've been kind of involved with this process all along, and I want to say thank you, because it has been hugely beneficial for patient care, allowing people access to care. It's been really amazing, and a lot of the changes that are in this rule are awesome. The idea that we're going to have gross debridements and we're going to have protective restorations are really, those are great benefits. There's just a couple of points that I have that are like tweaking that would help us, I think, in terms of how we see dentistry, where it's heading. The first one is on, I think it's page 2 for you guys on the periodic exam. And that this is as it pertains to the hygiene program and how hygienists are billing for that periodic exam, and how that is limited right now to 2 per year for adult. And the thing is as hygienists are going into like nursing home settings and into what we call co-location settings on the medical side, they're providing those exams, identifying pathology maybe, referring to a dentist, but the dentist still has to diagnose. And so when they bundled those codes together, the 0120, the 150 to 2 per year, then the dentist can't be reimbursed for an exam as it relates to caries, pathology, or restorability of a tooth.
Okay.
And so
I'm trying to find this on our rule. Has anyone?
Page 2 of 16. Stated on that.
2 of 16, which line?
Line 32.
That wasn't great.
Okay. 2 of 16, line 32. Great, thank you.
Sorry.
That's okay.
I don't have that in front of me, but just looking at expanding that as it pertains to a lot of those populations that are having exams done by hygienists, but yet the dentist actually needs to do the diagnosing to determine restorability or what we're going to do with that too, with those teeth. And it's not a problem-focused exam. They're wanting to treat the patient comprehensively.
Okay.
So for those patients that have limited access to actually coming in, or a dentist actually going out to that facility where hygienists are predominantly doing that, like in co-location projects and things like that, then that becomes an issue for us as providers, because
Okay.
we can't bill for those exams.
Ms. Tillman or Mr. Heller, one of you have is that something that could be looked at before next month?
It can be looked at, absolutely. I also, though, have to say we've already looked at this.
Okay.
And part of the reason, speaking in one of those two services, we did add per provider or location. So the flexibility has expanded past just 2 per year. And I'm going to have to look at a few things. We can't have duplicate billing for the same service on the same day, even if it's one's rendered by a hygienist and one's rendered by a dentist. So I will have to look into it, certainly. So we'll let you know.
Right, and I see not having them billable on the same day, because in co-location settings, predominantly, those are practices that are run by hygienists, and there's usually not a dentist on that team. Those are just going in and expanding the access through hygiene. And so I think that's reasonable, of saying not within the same day, but just being able to have the dentists that are then able to come in and be reimbursed for that.
Okay, thank you.
The next one is with the Full Mouth series. Right now, it's every 5 years, and the child benefit is every 3. And one of it is, once it's bundled, the way the ASO does is if you have so many x-rays, once it exceeds to a certain point, then it becomes considered a full mouth series of x-rays. Most of my patients haven't had care, maybe ever, with extensive dental needs. And so we take a full mouth set of x-rays where it really gives me good diagnostic quality. We get a lot of that cleaned up in that first $1,000 that first year. And then those x-rays are actually out of date. If we have to go off of those, even by just updating the 4 bite wings isn't enough. Sometimes I'm really needing to have those updated every 3, depending on the patient. And so, I think as dentists, we're trying to be, I'm very aware of radiation exposure and not wanting to expose my patients to more than is necessary, and really thinking that as we move to the digital, as we're looking at where dentistry is moving, having to then transfer those records, I think, and having that be our responsibility to give patients their records and holding that accountability to providers, I think is really good, and wanting to see that move. But seeing sometimes that as it consists with the child benefit and as well as some of these big changes that we see in our adult population, to see that move to every 3 years would be favorable.
What is the rationale for having the children's and the adults different there?
That's how it came through the benefits collaborative meetings when we were in the room with the providers. That was the agreed upon policy, and you'll have to forgive me, I wasn't in the same role then, so I can't speak to the finite details, but I believe you remember we brought Dr. Randy Tillman to present a little over a year ago, and she explained a lot of the rationale, and that's where the policy came from, recognizing that this is a limited benefit. And I can tell you, from someone who gets into the actual claims, I'm really seeing a lot of the annual maximum being eaten up by radiographs, x-rays. So again, walking that fine line without any utilization data in the first year, and just trying to make sure we're being as responsible to the clients and the legislature.
Great. Thank you. Mr. Heller?
Yeah, thank you, Mr. President. And to echo what Sarah said, I would also point out that there's a lot we want to do as we move forward. I mean, we want to be able to report on the $1,000 max, the impact of services on the $1,000 max, what builds that up. And so right now, with it 1 and 5 years versus 1 and 3, if we were to come back and say, let's change that, we essentially can get 2 years worth of data to see what's happening there. So I would just, I need to be fiscally responsible about this as well and make sure I'm not eaten into, much like would have happened with the denture benefit, that we use up the benefit. So that, I just wanted to put that out. Thank you.
Thanks. Ms. Roberts?
Thank you, Mr. President. I think that's a good idea to have that data, but I can also see your point, because by having x-rays every 3 years, you would be able to see, well, the erosion of the gums for one thing, if they needed to have, new procedures because of weight loss or changes, but also advancing periodontal disease or oral cancer, you could mitigate some of those thousands or hundreds of $1,000 costs perhaps by having this changed eventually, if not, whenever you get the information back, just because it would be fiscally responsible to prevent some of those major aggressive disorders that could happen too.
Right, and as we, digital x-ray goes forward, I think the thing that really helps is being able to just send those to another provider, so that you don't have those per provider, per location things that you have to have, because we have a responsibility to forward those films. And I think as we have that accountability, as the benefit moves forward, and not everybody in Colorado is on digital x-ray. Intercity Health Center, for one, is still on film, which we are duplicating and doing those things, but seeing as we're just on the cusp of getting that, and most people are moving into that, I think that accountability will be really be able to.
Ms. Ketchum, are you recommending switching it to every 3 years, or have an exception where you can go to every 3 years for individuals who, it sounds like some folks have, the mouth you're looking at 3 years from the first time is completely different.
Right.
I mean, are there exceptions that you're looking at there, or kind of across the board?
It's my experience currently is that the majority of my patients haven't had care for a long time. The mouth I'm looking at 3 years from now is totally different than the one that I get today. And so I would say that most of the patients fall into that. There is exceptions, of course, the people who are just, have had switching from the child benefit or the CHIP program, and now they're 22 years old and they look great. So, having that flexibility of being able to have that every 3 years, I think standard, 5 years is, I understand that standard as being okay, but I think for the population that we're currently treating, that needs to be in place.
Okay. All right, thank you. Other questions? Other points you'd like to make?
One, and it's just a typo, I think, and it's on page 16, and I think it's lines 11 and 12 maybe. I think this is just a typo. They're saying that they'll only pay for a surface up to 4 surfaces of a tooth on a given day, and there's 5 surfaces to a tooth. And the CDT code just says 4+, and this one just says 4, and I think it's just a typo, but missing the 4+.
It's not necessarily a typo,
Oh,
it's
okay.
just pointing to the ADA code, which is 4 or more surfaces. So,
Okay.
and that is exactly how it is in the children's rule, but if we need to clarify, we can, but we are not excluding the 5th surface. That's already how the ADA dental code book has it set up for those, but we can definitely make sure that's clear.
Yeah, because in the rule, I think in our
It states 4.
Yeah, it says 4, right,
Yeah.
so we're thinking, that's what it meant, so we were thinking if it's 4 or more, that'd be great. So it's just a typo.
Mr. Heller?
Mr. President, one other thing I just want to point out again is that we don't want to get, and this might not be the case, but I don't want to have detailed codes within the rule, because they change those codes every year. So we really look to the office reference manual, the billing manual with the codes to further define this information. That might not be the case here, but I just want to point that out too.
Okay, great. Ms. Roberts?
Thank you, Mr. President. Would it be possible to say per, instead of saying or more, just say per the ADA code? Or is that getting?
I've been advised by the Attorney General's
Uh-huh.
office to be careful about not accidentally trying to incorporate something by reference.
Probably wise.
So I will check with them about the best way to structure that.
Okay.
Great, thank you.
That's another star.
Yeah.
Yes. Ms. Ketchum, anything else?
No, I think that's it.
Great, thank you very much for coming forward with your testimony. I appreciate that. Next person to sign up, Erica, I'm not sure the last name. Is there an Erica that is signed up?
Maybe Eric?
Eric? All right. Then we have Antonio Martinez, who is signed up. If you could please come forward, introduce yourself, who you represent, and your position on this rule.
Hi, I'm Antonio Martinez. I'm the general manager of Martinez Dental, Our Kids Los Niños Dental, and ABC Mobile Dental. How are you guys? I did not get the email with this document, so I was just
Could I have
told-
you please speak into the microphone?
I
Thank you.
did not get the email with this document, so I was just told to come over and talk to you guys about a few things.
Okay.
We go into over 30 nursing homes throughout the Front Range. We travel between Pueblo and Palisades. Actually, we just started Durango. So our nursing home team has been doing this for over 5 years, and we see a lot of people in nursing homes, assisted livings, and independent living facilities, and we do mobile dental so they don't have to be shipped out. We have come up with some problems because just like in Dr. Ketchum's office, our nursing home has the self-developing film, and we have tried to submit some of those films to Medicaid for dentures, and they're getting denied. And then we just got digital, so to make it easier, and you guys are being great at approving them, but some of those people who had got exposed to radiation, they're refusing to take new x-rays, and there are some dentures that were not able to get qualified because of that. And I was wondering how we could work with you guys on getting the information to you, because one thing is we don't want to blindly send x-rays, because some insurances have been known to not send them back. And so that was one thing I wanted to discuss with you guys. And some won't open their mouth for x-rays, but they are edentulous. And I was wondering if you guys would consider a letter from the nurses or notes from the nursing homes, just saying, hey, this patient has edentulous, hasn't had teeth for years or whatever, something as a backup, because those seniors can be feisty. And we just want to give them proper care and help them eat, but sometimes it can be a little difficult. That's one point. And then the second point, with our kids.
Let's handle the first point first. Ms. Tilleman, thoughts on, or Mr. Heller?
Thank you, Mr. President. So this actually...
Why don't you move forward to the...
So this actually seems a bit operational as opposed to rule-based, and so we'd be happy to sit down with the doctor and go through some operational issues, and if we need be, I think we have some representatives from DentaQuest that we're meeting with next week. We can bring those points up. So if you'd like to outline, it'd be great to have something documented from you so that we can speak intelligently to the issue and kind of work that through the process. Be happy to do that.
Okay.
Perfect. And then also the $1,000 max when we do go into nursing homes. There's a nursing home fee that DentaQuest pays. Thank you for all the travel time and everything, and you guys are great at that, but then it eats up the $1,000 right away. And then we do get some approvals for dentures and partials, but then they can't afford to get the teeth pulled. And so I don't know if with certain places, with people with disabilities or maybe seniors, if we could do some type of appeals to add some extra funds or anything like that.
Is that more in some rural areas that you need to travel to and you're the only option, or are there other options available?
Well, there are some, there are a lot of, the people that are mobile, we have them go to the office. We'll do the exams, we have them go to the office for the work, so we're not eating up that time, and we have our own in-house lab, so we even have them do the steps there. But some of them that are not mobile or really difficult to transport, because most nursing homes, every time they transport someone, it costs between $150 and $500 depending on the transportation that they're using, so that gets costly too. But I know CHP Plus has that for some children. We can do a prior authorization if they needed a few dollars more each year, and they have been really good. And they're not approving everybody, but they're being really lenient about being able to get the proper work done. And I don't know if you guys could look into the possibility of doing something similar.
Mr. Heller?
Thank you, Mr. President. Dr. Martinez, thank you for your comments. I first need to point out, once again, and we've gone over this quite a few times, the $1,000 maximum, we need to look at the data to see where we end up at the end of the year, and understanding that we have claims run out, so it's not as though on July 1st I know exactly where we set for the rest of the year. But we're already, as Director Hammer can attest to, monitoring where folks are against the $1,000 max, and so we'll continue to do that. I would also point out that dentures are not subject to that, so if there's services that you provide that, and certainly many of the services for the dentures are included in that package of the code, but other services are still within the $1,000 max, so it's not as though the two are hitting up against each other. And so I just wanted to make sure that was clear. As far as the CHP Plus, I also have responsibility for that, so I will be very interested to talk to Delta Dental on why they're going over the maximum without approval from the department, because that's quite concerning, and I'd like to understand why that's happening and where, because that's not appropriate, that's not their decision, that's the department's decision. Certainly they're on a capitated model, so if they're eating that dollar and not charging the state, I'm fine with that. But if the state's paying for something beyond what we've contracted to, I'm very concerned. So I appreciate you bringing that to our attention. And then I'll let Sarah jump in on some of the technical issues if you don't mind.
Okay.
Mr. President, members of the board, I just...
I'm Alan Kisler.
Come up to the table and introduce yourself.
Thank you, Mr. President. Good morning to the board. I'm Alan Kislowitz, and I'm the contract manager for both the Medicaid Dental and the CHP Plus Dental. In the past, prior to July 2014, Delta Dental had a process where the foundation had funds whereby the dentist could request extra funding if there was medical necessity and the CHP member ran out of their annual max, and that was set at $600 prior to July 1st, 2014. Since that time, and that process has been going on for many years. That was a Delta Dental process. It wasn't billed to the state. It was just coming out of their Delta Dental Foundation. After that, after July 1st, 2014, we have raised the maximum for those children in CHP Plus to be commensurate with the Medicaid program. So it's $1,000 annual max. And once that kicked in, the Delta Dental Foundation withdrew the opportunity to use their funding.
Great. Thanks
so
for that
that's where
clarification.
We're at
now. Great.
Thank you.
Dr. Martinez, I'm not sure if you've seen the final or the initial rule that's set up. So I would ask for the department to make sure Dr. Martinez gets this rule. How the process works is that this is an initial approval stage, at which point then it would need to come back at a future time, maybe next month, for final approval, where any and all these things hopefully can be ironed out with the department. So are there other specific areas in the rule that you have concerns or questions?
Truthfully, I have not even had time to read the rule. I was just told to come to the meeting. So I'm here.
Okay.
And then the children's office has asked me to just see if you guys can add the code for the missed appointment without 24-hour notice. I guess in 3 other states, DentaQuest is doing that. And we're having a lot of people miss, and so they were just wondering if we can add that code.
Ms. Tillman?
Mr. President, members of the board, I would like to point out that it's against federal regulation for Colorado Medicaid to allow the billing of clients for missed appointments. That would be 42 CFR 440 is the citation. The three legs of being reimbursed for a service is a client and beneficiary must be eligible, a provider must be enrolled, and the service and benefit must be covered, and missing an appointment is not a service. So just a little explanation around why we will not be able to accommodate that request.
Appreciate it. Thank you.
Cool.
Thank you
Well,
very much
you
for your
guys this
testimony,
thing,
Dr. Martinez.
and I'm wondering if I can get a copy of this.
We'll make sure to get you a copy.
Thank you.
Thank you. Is there anyone else that would like to testify on document 5?
Mr. President?
Yes.
I received by email this morning some written comments. However, I don't really have any method to get them to you right now. Happy to email them back out to you.
Okay.
We would have them after the meeting.
Very good. All right, thank you. We'll have that before next.
And
Ms.
Mr.
Tillman?
President, and members of the board, I'm hoping you did see the letter of support from Colorado Community Health Network.
Yes, thank you for that reminder. Dr. Malinkovich?
I have one question about one of the issues that was first brought up by testimony around multiple locations. And is that an issue?
No, if you're worrying that somehow when we say per provider or per location, we're getting funny with location, no, we're looking at billing address. So if it's a Comfort Dental practice, for example, with multiple locations and they end up in one office in Durango and then another office in Denver, those are different locations, so they would.
But the example that was brought up was around, say, a hygienist billing for a service in one site and then referring the patient to a dentist who then can't bill?
I need to explore that further, I need to understand why the same code would be billed for that, if it's technically two different services, et cetera, et cetera. So I'm going to need to discuss that with Dr.
So when this comes back, you can clarify that?
Absolutely.
Okay.
Great, thank you. Other questions from the board on this? Nobody else has signed up for public testimony, so all those in favor of initial approval of document 5, please signify by saying aye. Aye. Ms. Blakely?
Aye.
Aye. All right, we've got initial approval of document 5. Thank you both very much. I'm going to recommend a quick 5-minute break before we continue, so we'll adjourn right now and be back in 5 minutes. But we still have a quorum, so we're going to go ahead and get started. Could I have a motion for document 6, please?
Sure. I'd like to move the initial approval of document 6, MSB 14-12-03-A, revision to the medical assistance eligibility determination rule concerning the Medicaid buy-in program for working adults with disabilities and the Medicaid buy-in program for children with disabilities, section 8.100.6.P and section 8.100.6.Q, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Got a motion and a second for document 6, and we have Beverly Hershikorn here to present. Welcome.
Hi. Hello, Mr. President and board members. My name is Beverly Hershikorn. I am the Disability Agent Policy and Program Performance Coordinator associated with the Eligibility Division. With me is Chris Underwood. He's the Director of the Health Information Office for the department. Today I'm here to present the rule concerning buy-in premiums being charged the month following approval of the buy-in program and the addition of an opt-in function for members that are approved for the Working Adults with Disabilities and Children with Disabilities buy-in programs. The intent of the rule is to enhance the consumer experience by first charging premiums only after a person has been approved for eligibility, and second, proactively allowing a person to choose to opt out of the buy-in programs to be considered for any other Medicaid category they may be eligible for, going down the Medicaid program hierarchy. Currently, premium letters are being generated sometimes months after an application that are charging premiums back to the day of the application. We are implementing changes to CBMS in March that will mitigate hardships for individuals by charging premiums in the month following the approval processing of their application for both adults and children. With that change, we are also simplifying the premium letter with suggestions by the stakeholder community. There are no needed rule changes for the clarified premium letter. We have also listened to the feedback that some people would like to choose not to pay premiums, but to be considered for other non-premium Medicaid programs if they qualify. Again, changes to CBMS that will be implemented in March will instruct individuals on opting out of the Working Adults with Disabilities and Children with Disabilities program through either their approval notice of action or through a decision box on PEAK. We've been working closely with stakeholders through the Attorney General's office to improve the buy-in program experience and mitigate challenges and concerns for our members. At this time, that's all I have, and if you have questions, I'm happy to answer.
Questions from the board on this rule? We have one individual signed up. Josh Winkler, please come forward. Introduce yourself again, who you're representing this time, and your position on this rule.
Thank you, Mr. President. You're right, I am actually. I'm Josh Winkler, and this time I'm representing the Colorado Cross Disability Coalition. I believe Julie Riskin sent some written comments, or she will be later today, on this rule. And we appreciate the department addressing this because it's been an ongoing issue with the buy-in. Well, the buy-in has been out now for about 2.5 years, I think, going on 3 years. And we're at over 3,000 people on the adult buy-in, 400 kids on the kids buy-in, which is good to see. There has been some challenges, and premiums have been one of those. The one question that Julie had was around those who are already caught up in this premium issue and have received letters or are in the appeals process because they're being asked to pay premiums in some cases for months that they either did not have Medicaid eligibility or did not know that they had Medicaid eligibility. And if there's a way that can be taken care of, not just for those people who reach out each individually to the department and get individual waivers, but to just, retroactively for those who are caught up in this, somehow take care of that.
Mr. President, that's exactly what this rule is intended to mitigate. We strongly recognize that because each of those appeals or those individuals that have reached out come directly to me.
Right.
And I have fielded those.
It sounds like the rule, though, will be going forward. I think Mr. Winkler's concern is those individuals retroactively.
We are looking at what we can do to mitigate that. It's my understanding that those will be as well taken care of, but in as much as every time we do a change to CMS, we're always looking to see how that's impacted the system. I'll be watching very closely to make sure that's been taken care of, and if not, we'll adjust it.
Okay, thanks.
Okay.
And hopefully this time next month, I'll be able to say the system worked. I reported my income 2 days ago, and I forget what it says on Peak right now, but it's pending review, I believe. So I'll find out in a couple of days whether or not.
Come back next month and let us know, all right? How that works. And I have not received any testimony yet from Ms. Riskin. Have we? Okay, all right. We'll look for that.
Next few days.
Okay, great. Thank you very much for your testimony. Any other folks there that would like to sign up for public testimony on document 6? And seeing none, we have a motion and a second for initial approval of document 6. All those in favor signify by saying aye.
Aye.
Ms. Blakely?
Aye.
All right, we have initial approval of document 6. Thank you very much. Motion for document 7, please.
Move the initial approval of document 7, MSB 14-10-02-A, revision to the Medical Assistance Delivery System and Payment Innovation Program Rule concerning emergency transportation services, Section 8.018, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Got a motion and a second on document 7, and we have Greg Trolin signed up. Welcome.
Thank you. Good morning, Mr. President, members of the board. I'm Greg Trollin. I am a programs manager in the newly named Delivery System and Payment Innovation Designs Division of the Health Programs Office.
You guys are all getting longer
Yes.
business cards, aren't you?
We are. We're coming up with interesting acronyms as a result of that. So I'm here to present the Emergency Medical Transportation Rule. This is very straightforward. We're essentially in this process of taking the benefits collaborative standards that were already developed for this particular benefit, putting them into rule, taking the substantive content that's in that benefit coverage standard and moving it into rule. As you're well aware, there are several benefit coverage standards where we've taken those specific contents and moved them into rule as part of our process of essentially not being able to reference specific benefit coverage standards, but actually having to have those in rule. And so that's the process that we're going through today. So essentially, we had this process for the benefit coverage standard that was thoroughly vetted through stakeholders. We also, as we brought this up, reached out to the emergency transportation industry to get feedback about this particular rule. And all feedback from those entities came back as that they had no concerns or issues with the contents of the rule.
Great. Questions from the board on this rule at all? It did seem pretty straightforward. We don't have anyone signed up for public testimony, so if there's no other questions from the board, all those in favor signify by saying aye.
Aye.
Aye. Any opposed? Ms. Blakely?
Yes, aye.
All right, thank you. So we have initial approval of document 7. Thank you very much.
Thank you.
Looking at the rules that we've gone over today, I guess I'd be recommending that we put documents 4, 6, and 7 on the consent agenda.
So moved.
So we got a motion. Do I have a second for the consent agenda?
I second, and yes, I agree.
All right. Thank you, Ms. Blakely. All those in favor, signify by saying aye. Aye. Any opposed? Ms. Blakely?
Yes.
Okay. Then could I have a closing motion?
Move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference.
Second.
Got a motion and second. All those in favor, signify by saying aye. Aye. Ms. Blakely?
Aye.
Very good. We are closed. Public testimony, nobody has signed up for public testimony. Would anyone? Come on, back there. It's your chance. All right, nobody has signed up. We'll move on to the department update portion. And we have received some written testimony on House Bill 1293, the hospital provider fee update. So make sure to look through that when you get a chance if you haven't already. And then Kyle Brown. Is Kyle Brown here? Yes. To give us an update on the provider screening update.
You have it. Yeah, that's great. Good morning, Mr. President and members of the board. My name is Kyle Brown. I'm formerly with the department. I now work at in the office of the governor. When I was moving over a couple of weeks ago now, I committed to finishing this process with this rule, and so that's why I'm here today. This rule represents kind of a major change in the way that the department is required to enroll and screen all Medicaid providers. And so today, I'm going to outline the rule and some of the requirements that have been put upon the department by the federal government, so that you guys know kind of where the process is. But I'm not asking, obviously, for any sort of formal adoption of the rule or initial consent at this time. This is just an informational thing at this point. So I've brought some handouts for you all that you guys can follow along, but we'll also have it on the screen, so I'll go ahead and get those around. I've also got another couple of handouts here, and there's enough for the public as well. Those would be helpful. Thank you. I've got a copy of some copies of the initial draft rule that we've been working on and that have been circulating. It's available on the department's website, as well as, and has been circulated among stakeholders, so I'll make that available to you all as well. Hopefully that's enough what I just gave you there. And then I also prepared a document that is kind of the department's, a summary of comments that we have received on this rule and responses to those comments. This process has been one where we have really done a proactive, try to be very proactive about our stakeholder outreach even before we reach this public process. And so it has involved a lot of individual calls to as many different types of providers and provider groups as possible. So I wanted to reflect that as well, and I'd be happy to talk about that more. But let me talk a little bit more about the specifics of the rule before we get into that. So today I'm going to talk a little bit about what the federal requirements are that this rule is based in. I'm also going to discuss what little flexibility Colorado has and the timeline that we've set out for the implementation of the rule. So the new federal requirements are really, they're designed to prevent waste, fraud, and abuse in the Medicaid, Medicare, and CHIP programs, and they do apply to Medicare as well. There's a specific section of the Affordable Care Act that requires CMS to develop new procedures to screen providers, and the final rules were promulgated a number of years ago and published in the Federal Register. And briefly, what they do is they require providers to periodically revalidate their enrollment. This is a new requirement that we've never had before, that every so many years providers need to come back to the department and revalidate their interest in being a Medicaid provider. The federal government also requires providers to pay an application fee, and that application fee is designed to pay for increased screening of providers to prevent against waste, fraud, and abuse. That screening divides provider types into 3 basic categories based on their risk or perceived risk of waste, fraud, and abuse. And those screening, or those risk categories, have different screening procedures associated with them. So as I mentioned, the providers have to revalidate their enrollment, and that has to happen every 5 years. Currently, all of our enrolled providers have to be re-enrolled by 2016. And that screening, and then the screening must be conducted on all enrolling and re-enrolling providers. So that's something new. The department has had a screening process prior to this, but it has not it is not currently in compliance with the federal standards. So we are updating those to be in compliance with the new federal standards.
In the process of revalidating, are the providers recommitting to a certain percentage that they'll be serving, or?
There is actually no requirement that they even take any Medicaid patients. It's just about re-upping their address and all of their various information, and then going through the screening process to make sure that they're not crooks, essentially.
Okay. And I'm not sure how this works necessarily. The experience I've had is more on the mental health side for Medicaid, where individuals say, yeah, we're a provider, and then they don't really provide.
Right.
And then yet, it's looked at as we've got plenty of providers and they're not approving new providers. So that's a concern as we move forward.
Yeah, so I appreciate that concern, and there's a complexity, obviously, in the behavioral health side because of the interaction of the BHOs and the discretion that the BHOs have to develop their own networks. But I can tell you that as part of this rule, all of the BHO's providers will need to be enrolled and screened, and so that gives the department some additional understanding of the networks that the BHOs have and the extent to which we have adequate coverage.
Okay. Thank you.
So another major part of this rule that is required by the federal government is any providers who order, refer, or prescribe for Medicaid clients must be enrolled with Medicaid. And operationally what that means is that the National Provider Identifier must be on all relevant claims. So if you're a provider and you don't take Medicaid, but you are, currently you can be a provider and not take Medicaid, but you can write a prescription or you can refer for one of our clients. Under the new rules, the new federal mandate is those folks who are ordering or referring or prescribing need to also be enrolled and screened in our program. So I mentioned that there's some application fees that are required under this new rule. The fees are designed to offset the federally mandated screening program, and the fees are actually enshrined into federal law, and the amount of fee is as well. And so we, as a state, are required to collect application fees on all enrolling and re-enrolling providers, with a few exceptions. Individual physicians and non-physician practitioners are not required to pay a fee, but physician groups and practices are. Providers who have been enrolled in Medicare and have been screened within the last 12 months are not required to pay a fee, and providers who are enrolled in another state's Medicaid or CHIP program who have been screened within the last 12 months are also not required to pay a fee. That's assuming that the other state's screening requirements are consistent with Colorado's. There is some flexibility in implementing these, and so the rule reflects that the screening requirements of another state must be consistent with ours. The fee is around $553. For next year, it goes up with inflation every year, and again, that's enshrined into federal law.
Dr. Markovich?
Question, is that $542 per physician group, or is that per provider?
Per institution.
Per institution?
Yeah, so per physician group, the hospital, the DD provider,
Yep.
whatever.
Yeah.
Ms. Roberts?
Thank you, Mr. President. Is this exclusive of the fee that we paid at CDPHE for licensure, I assume?
It's different, yeah. So it would be in addition to. Yes.
Okay.
So let me talk a little bit about the federal requirements around screening. Screening procedures, again, are based on the risk category that a provider falls into. There are three different types: limited, moderate, and high. Limited risk providers are required to meet all federal, state rules and regulations, have their license verified, and be checked against databases that exclude providers that have, committed fraud in the past, or there's some reasonable assumption or some reasonable suspicion of that. This is very similar to the screening that we currently conduct in Colorado. And so most of our providers fall into this limited category and won't see their screening really change. And all of this is done on the back end. So a provider filled out their application, all this stuff runs in the background, and then they get an acceptance. So very little difference. If you are designated as a moderate risk provider, you're required to go through all of the screening procedures of the limited risk level, but pass an on-site inspection. And this is an on-site inspection that is not related to licensing that CDPHE would be conducting, but it is an inspection that is fraud, waste, and abuse oriented, right? So the concern here is that DME providers or certain types of providers, not to single any one group out, might be setting up kind of shell businesses and then billing us. And so some of these on-site visits are literally like, does this provider have the capability to provide services? Do they have inventory? That kind of stuff. High-risk providers are required to meet all of the screening procedures of limited and moderate, but they also must pass criminal background checks and be fingerprinted. And again, this is in addition to a criminal background check or fingerprinting that would be associated with licensure for some providers. So as far as assigning risk levels to different provider types, the federal government has actually done most of the work for us. A lot of providers have been assigned a risk level by Medicare already, and the state is bound by that assignment. So we have to either assign them the same level or higher. But Colorado has some flexibility and has to make decisions about risk levels for our Medicaid-only provider types. So you can think of specifically our HCBS waiver providers or some of our non-medical transportation providers, those types of things. So let's go through a couple of those categories. So the rule does not, the way the rule is drafted right now, it does not specifically call out the list of limited risk providers. There are just simply too many of them. But here are some examples: physicians, hospitals, FQHCs, pharmacies, and again, anything that's not specifically listed in the rule falls into limited risk. On the next slide, I list some of the moderate risk providers that we've listed. And again, most of these are pursuant to the federal requirements. Ambulance service providers, community mental health centers, hospice organizations, portable x-ray suppliers, and then home health agencies and DME suppliers that the state has done business with before and are re-enrolling. Some of our HCBS waiver providers also fall into the moderate risk category. So groups like group home providers, non-medical transportation, rehabilitation, and the full list is in the rule that I passed out to you. There's a small number of providers that are considered high-risk providers. Any newly enrolling or prospective home health agency or DME supplier is considered high risk. Providers, any provider in any category that is on payment suspension based on a credible allegation of fraud, waste, and abuse, anybody who has an existing Medicaid overpayment, and a provider that has been excluded within the last 10 years from either the Medicare or Medicaid program has to be considered high risk. And again, there's really nothing we can do about those. That's federal requirements. So on the next slide, I talk a little bit about the implementation in Colorado. We really don't have a lot of flexibility here. We are required to screen all the providers, and I've gone through some of the highlights, but that just summarizes where we have asked for stakeholders to weigh in, and what we have attempted to do in the draft rule is we've asked if there were providers that should be subject to screening procedures beyond the CMS requirements. We've taken some feedback on that. We've also asked, following CMS's guidance, to what levels our Medicaid-only providers should be assigned, and we've taken some good feedback on that. We actually had a special webinar specifically with our waiver providers, in addition to another webinar that we did for the larger community. Following CMS guidance, we also ask what pre- and post-enrollment site visits should look like. So the implementation of the site visit itself, we have a significant amount of flexibility on. We've looked at what other states are doing and tried to come up with sort of best practices and a consensus of what those site visits should entail. That is reflected in the rule. But we really were interested in what various groups, especially those that would be subject to a site visit, would tell us. And then we realized that this is new, we don't have a lot of say in it, but we were really interested in if anybody had any ideas about ways that we could reduce any potential burden on our providers. And we took some good feedback on that. Just to mention a little bit of the stakeholder process, so we can take a look at the next slide timeline. I just want to talk a little bit about the process that we've been going through here. I kept a log of all of the stakeholder conversations that I had since September on this. And it's quite extensive, and I won't bore you with it. But it is. But I just wanted to let you know that we talked to physicians and hospitals and the Colorado Medical Society, the CBHC, the Behavioral Health Council, the FQs, the nurses, DME providers, nursing facilities, pharmacists, Denver Health, the BHO specifically, Rocky Mountain Health Plan, some other smaller providers. And then I mentioned that we have done extensive outreach to the waiver provider community because that tends to be, smaller groups of individuals. So that we wanted to let them know that this was coming and that there would be some changes for them. I made presentations to the CHP Plus plans and to a number of our advisory groups, including RICO Ops, the PIAC, and the list goes on. So if you have specific questions about groups that we may have been talking to, be interested in that. We also set up as part of we posted the rule online early in November, and we took formal public comments in writing through a designated email site or email address for the month of November. And so we took feedback on that. That's what's in part what's reflected in the handout that I gave you. So that was another opportunity for folks to weigh in. We reviewed all of that feedback from all of these conversations and during December and made edits to the rule, and the rule that you have in front of you reflects all of those edits. That's also posted on the website. And then now we're beginning the process of your consideration of the rule and hopefully moving towards an effective date of June 2015. The actual implementation of the rule and screening will begin later this year and will be carried through to the middle of 2016. The good news about all of this is that it's taking place at the same time that the department is rolling out a new web-based provider enrollment tool as we re-procured the new MMIS, and Chris is the expert on this, so I'm really glad that he's with me here. But this new MMIS has this web-based provider enrollment tool, so there will no longer be this manual paper-based process where people have to submit their applications and go through Xerox and everything. You can log on through the portal and follow a wizard to get enrolled and start an application, finish it later, check the status of your application, and set up electronic funds transfer. So even as there are new requirements coming down from the federal government, hopefully the process will be getting a little bit easier on our side. So as I mentioned, there's a lot of updates on the website. All the materials that I've given to you today are posted on the website. And we were collecting comments at that particular website or email address earlier this year. And then if you have any questions, I'd be happy to answer them. I'll also say that since I am in a new role now, Chris Underwood here is really the point person for the department on this rule.
Questions? Ms. Riley?
This may be a rhetorical question.
Okay.
But can I assume that the feds gave the state money to implement?
The money is supposed to come from the fee that's assessed on providers. So Congress designed this to be budget neutral,
Okay.
both in Medicare and in Medicaid, because they were afraid, I'm gonna speculate a little bit, but I believe that they were afraid of the Congressional Budget Office scoring this negatively when they were passing the Affordable Care Act in the first place. So the fees, unfortunately, the provider community is required to pick up the tab for this screening.
So then has the department done a fiscal analysis to see if you're going to get enough from fees to pay for what you need to do?
I think those are ongoing discussions with the budget department right now. It's hard to know exactly. If we exceed, if the department needs more money than the fees provide, then we will get matching funds from the federal government. Obviously, we kick in some too. If we end up collecting more fees than are required, we actually give that money back to the federal government.
They have already asked me once, where's their money?
I'm not surprised.
Question?
Yes, Ms. Hughes.
Mr. Brown, is there any concern that you will possibly lose any providers because of these new fees?
Yeah, there is concern, and a lot of providers have raised those exact comments. The fee in particular has been a point of heartburn for the provider community. And I will say that the rule allows for the exemption of providers for which this is, the fee would be a hardship. And the department is going to be pursuing a broader exemption for certain types of providers on kind of a categorical basis with the federal government. The unfortunate thing about the fee is that the state doesn't have unilateral authority to waive fees. All fee waivers, whether they're on an individual basis or a categorical basis, have to go through the federal government and get approval. So they're the ultimate arbiters of who gets a fee waiver.
And we will actively be seeking waivers to exempt as many providers as possible from the fees. We heard that Utah got a broad exemption from the fees for almost all their providers just because they could declare them to be in rural areas and access problems. So we are actively going to be working on those waivers to lessen the hardship on our providers as much as possible and send less of that money back to the federal government.
Dr. Mikovich?
Thanks. I actually have two questions. What's been the general response from the provider community about the rule? And I was kind of trying to scan through the feedback. And the second question is, you mentioned a number of entities that you've been soliciting feedback from. Have you worked with some of the professional groups like American Academy of Family Practice, American Academy of Pediatrics, the Society of General Internal Medicine, which have a large number of primary care providers, in addition to the CMS?
So we did reach out to the family physicians, and didn't get a lot of interest. I would say they were interested, but given that doctors in general, all doctors, right, internists, whatever, pediatricians, fall into the limited risk category, and that individual providers themselves are exempted from the fee, there hasn't been a lot of heartburn on the physician side. Did I answer your question? Did I miss something?
No, I think at least you mentioned there has been a lot of heartburn on the physician side. Right. I suspect a lot of the concern is on non-physician providers. Is that right?
The site visits are a point of contention.
Any other questions? We're hoping to see then this rule in the next couple of months, it sounds like.
You definitely will.
Great. Great. Thank you very much for the update. That's very helpful. Gretchen Hammer.
Yes, sir.
First time here.
Indeed.
First update. Welcome. You've been here for over a month now, so you'll know everything we ask.
Yes, of course. I mean, I would like to, actually, while Kyle is still in the room, the other thing that we've talked about, and you may remember last month, I had the opportunity to provide an update on access to care kinds of questions, that this will enable us to get another touch with all of the providers that we have the opportunity to engage with. And so, we think this will also be a data collection opportunity, or at least a landscape analysis. And so there are some additional benefits beyond just the actual compliance with federal regulation.
Thank you, Kyle, and good luck in your new role.
Thank you.
Terrific. Well, thank you. It's been a pleasure to be here and to participate in the meeting today. I do have just a couple of important department updates that I think are worth bringing to you, but I hope they won't take us too long to work through, given the late hour. The first is the department is building and currently recruiting for a Person and Family Advisory Council. This is part of a larger initiative within the department to infuse a person and family-centered approach into the department through our policies, our processes, and our procedures. So there's a recognition that that's important. I think the rule review that we went under today that even just removed offensive language is a good example of how we might imagine this playing itself out. The council is being initiated through some funding, but it is the hope that we'll find a way to continue to have this be an important part of the stakeholder infrastructure that guides the department's work. It's, again, going to be with families and clients and designed to help us look at all of the ways we interact and make sure that we're doing things with patients and with families instead of doing things to them or for them. And so I think it's an important piece. The council will consist of 7 to 15 members and will have 4 to 6 facilitated advisory committee meetings in its first year. We have extended the deadline for applications, and again, this is designed to be an opportunity for, and since I used to be a paid advocate, I will say this with my own experience, for non-paid advocates, but for those who are actually served by the program or who have family members served by Medicaid. And so it really gives us a glimpse into the kinds of experiences I think we heard today with that guardian versus individual signing, to really have a chance to have a systematic thoughts about those kinds of things. So we're doing more targeted recruitment and need representation from the Eastern Plains and Western Slope. So there is an attempt in the configuration of the council to have it be representative of the kinds of people who are served by Medicaid, as well as the breadth and depth of the state. So if you know folks, please refer them to us. Carrie Cortiglio is playing point on this, but I'm also happy to pass along anything, or Judy, if that's easiest for you. We had Zach here to provide the update on the legislative update, but he mentioned and turfed over to me, if you will, some of the discussions we're having with the Joint Budget Committee. There has been a bill introduced around what would it look like if we had a Medicare floor as the point which would tie Medicaid rates to that. So it was a bill proposing setting a floor for Medicaid rates at 60% of Medicare rates. We have started some analysis, and there are 17,000 codes that we have identified within Medicaid, and about 2/3 of them have an equivalent Medicare code. However, some don't, as you might imagine. Well child visits, for example, or certain maternity services, or our home and community-based services that don't have an applicable Medicare code. And so we've been reflecting back and in conversations with the Joint Budget Committee about sort of the ease of part of that analysis. That it would, when you have a Medicare code to compare to, we can see what proportion we are at. On average of those 11,000 plus codes, we're at about 71%, but that's a cautionary number. If you start to really dive in, for example, to the surgery codes, we're at 40% for some surgical services and at 78% for other surgical services. So that average number can be misleading. And so we're in continued conversation about whether or not this is a piece of legislation that will move forward. It is, I think, a piece of a larger conversation that we've been having, I'm sure, here and with the Joint Budget Committee about the rate review process for Medicaid rates in general. And so we have had a consultant helping us to map out what a long-term rate review process would look like, so that similar to the rules is how I've been thinking about them. At a certain cadence, every 5 years, for example, we would look at a certain subset of our rates, analyze them as to whether or not there's access to care issues, analyze them as to whether or not they're appropriate for the current market conditions, and then make adjustments to them. And so about every 5 years, or on some similar cadence, again, like our rules, we would have a chance to look at those. There are not current resources allocated to that, and so again, that's part of the conversation we're having with the Joint Budget Committee. We also, a third component of this rate conversation is in relation to the targeted rate increases. Last year, the General Assembly allocated certain resources towards to the department to do targeted rate increases in the absence of this larger rate review process. And so far, we have had positive feedback from last year's targeted rate increases, which again were designed to look at codes that were so potentially low that they were impacting access to care, and or were just some services that if we had perhaps better payment rates, they would be used more, and therefore we'd get better health outcomes. So, for example, eye exams have been a good example of an improved access and improved provision of services, as well as pediatric developmental screenings are some, again, from last year that have been implemented and are starting to show good impact. We are presenting and currently, like during these hours right now, finalizing our recommendations, which are due to the Joint Budget Committee this afternoon, for the rate increases that would be part of fiscal year 2015 and 2016. So the budget request was for about $16.5 million. There's been a robust stakeholder and analysis, and we'll be presenting those proposed targeted rate increases for the next budget year to the Joint Budget Committee and having public testimony around those on Tuesday of next week. The Benefits Collaborative was another piece of update. 25 benefit coverage standards have now gone through the Benefits Collaborative, and I think we have held it out as one of the places where stakeholder engagement and the process seems to be working, seems to be getting a lot of positive feedback. There are 3 more that are in queue: substance use disorder, pediatric personal care, and wheelchair services, and those will be published to the department's website next week. There are also current stakeholder meetings that are convening regarding the development of genetic testing and private duty nursing benefit coverage standards. So again, as we look at being good stewards of our resources, maximizing our utilization management vendor, and then aligning dental standards with current practice, a little bit like the dental conversation we had today. This process really enables us to do that. And then there's also, and I think it was mentioned at the last Medical Services Board, the revision of the medical necessity definition. I think Dr. Zerzan shared that it's defined a couple of different ways in a couple of different places, and that certainly is adding to some confusion. Collaboratives on the horizon include those around transgender services and children's orthodontia. And then 9 benefit coverage standards are up for the 3-year review this year. And information about how stakeholders can participate are being posted At a Glance. And then the department continues to convert the majority of content into these standards into rule language, like the emergency transport today, so you'll continue to see those kinds of rules. The fun stuff, social media. The department is joining the rest of the world on social media with a presence and a plan that started on January 30th to have Facebook, Twitter, and LinkedIn. These channels will be just an additional channel to engage with our varied audiences, including stakeholders, including thought leaders in this work, the media, healthcare providers, and certainly then those that we serve. And then Human Resources is exploring the options of using LinkedIn, which is a little bit more of an employment-oriented social media platform, to be part of our ongoing recruiting and those kinds of things. So you'll start to see us more. The Program and Communications Office has a very robust strategy in place, and I think it's been a very well thought out and amendable to changes as we see what kinds of impacts we're having. And then lastly, I know Brenda's got bags under her eyes because of all of the work on this, but enrollment updates. So open enrollment ends at the marketplace on Sunday. As you all know, enrollment in Medicaid is not tied to that deadline, but it's an important push nonetheless. Customers there have been extended call hours, pop-up places for people to go, as we anticipate, as we have seen in the past, that despite everyone's best attempts as human beings, we tend to put things off, and so we do anticipate a rush of late customers, as we saw last year in both of the December and at the end of open enrollment. For customers who've started the application process by the February 15th deadline, there will be continued assistance to get that done. There's not a drop-dead cutoff date there. And the latest enrollment numbers from November 15th through January 31st are that Connect for Health has enrolled just north of 125,000 individuals, so 125,379. And that Medicaid and CHIP have seen an enrollment of just north of 61,000, so 61,119 individuals.
Since December 31st?
Since
Or since inception?
November 15th through January 31st. So not including any February enrollments at this point in time in those numbers.
And that's total new enrollment?
Those are new enrollments.
Wow.
Brenda, does the Connect number include renewals as well?
I don't think so.
Okay, okay. I couldn't, it is written here as if they are new enrollments, and so we'll go with that, and if I need to correct next month, I can, or we can correct in electronic communications. So that's it from the department, unless you all have general questions.
Questions at all? Ms. Roberts?
I was wondering, Gretchen, if, do you have any verbiage on the solicitation, particularly northeastern Colorado? I could contact the Health and Human Services people in our 6 counties. We cover 10,000 square mile. We had to come up with 2 or 3 people that might be interested.
Yes.
Are the meetings coming to Denver 4 to 6 times per year, or being Skyped, or can they do it via phone, or?
Yes, there will be accommodation, and I don't know if the meetings will move around or not. That's an excellent question. But yes, there has been open discussion about if we're looking for statewide-ness, we need to have the right kinds of accommodations to work for that. So yes, it was in at a glance, and I know there's a link on the website, so I can work with Judy to make sure we get that out to you, which is very reasonable if we're asking for some help there to give you the resources to fulfill that request. So, yep, absolutely.
And are you specifically wanting, I have a good friend, for example, who's a grandmother to a child who is very definitely DD, has been with the Medicaid system for years and talks to me about some of the glitches. Or a family-based, or what are you specifically looking for, or just someone interested and will participate?
I think it's all of the above. I think, again, there was, the goal was to have individuals who are directly impacted, individuals or family members who are directly impacted by the programming of the department. And so, again, we know the advocates have a perspective, and that's important, and we try and create a variety of forums for stakeholder engagement in that level. But this was really designed to help and to reflect back to us. It doesn't feel so person-centered when you do things like send out letters we can't read or don't understand, right?
We did the same thing with the pediatric hospice waiver years ago. There was a huge group of individuals that would have benefited by the benefit had it been present, and hearing those stories were similar to those that we heard from when the pediatric assessment tool changed.
Exactly. Yep. And even, I mean, we've talked about and used examples in the payment of the CHIP premium. You know, there's every month there's a reconciliation process, and you know, if we could look at that and say, is this the right way to be doing this? If every month we have to do some sort of adjustment or workaround, is there not a system change upstream that if we all had some thinking together we could improve? So I think it's not only policies like here, the rule setting, but general processes, customer service training for staff. It's all those kinds of things that will help us to embrace and incorporate a person-centered and a family-centered approach in the work of the department.
Thank you.
Yeah.
Other questions or comments? Dr. Milankovich?
At last month's meeting, I think it was last month's meeting, we passed as an emergency rule the EPSDT's rule, and there were some questions still about applicability in schools. And I just remind, the department was going to bring back some clarification around that, so if I could just remind Gretchen.
Yep. Yep, I remember the conversation well, and I apologize we didn't get it for you. Yep.
No apology needed. I just want to remind you that I'd like to hear.
Great.
Anything else? All right. Thank you all very much. We'll adjourn, and we'll see you all in March.
There are some sandwiches.
All right. Christy, thank you very much for hanging on there. Get well.
Bye, thank you.
All righty.